Blackwell, so we're sort of related. Yeah, so I'm going to turn it over to Dean. Welcome.
He's my grandfather. I can say that because he's not. So we're going to go through kind of a tough topic in 2 hours, and that's the world of introducing you to pain and the management of pain. By no means are we going to touch on pain conditions per se, so we're not going to walk through individual conditions that you're going to get as you're working through your training in each of your different systems-based reviews. Some of the initial neurophysiology that we'll discuss, I know you've kind of touched on spinal cord, maybe, what else?
Brainstem.
You've done spinal cord and brainstem, so you've not done any cortical structures, deep brain structures. We'll touch on those. They've got to be introduced at some point, and then you'll end up, I think, next week you'll end up doing deep brain, cortex, that kind of stuff. Neuroanatomy and neurophysiology is a love of mine. I got a degree in biological psychology and neuroscience before I went to PA school. So I've known Dan and some of the other folks a while because of that. So we'll talk about some of the neurophysiology side of it, and then we'll walk through sort of general pain, and we'll touch on some pain management, which is a very wide topic. I've been in pain management now full time for about 9 years, and it's an ever-changing target. If you ever watch the news, you can kind of see what we do is a hot topic right now. So we'll sort of touch on some of that. At any point you have questions, don't wait till the end. You can stop me. It's easier to go through it then than have to kind of advance backwards in the slides and so forth. At any point if you have questions after this, you can always contact me. Either Dr. McNeil can get a hold of me, or all my stuff is there, and you guys can download all that. This lecture partially is adapted from the University's Wisconsin School of Medicine, just so I give them props, and I've got nothing else to disclose financially. So there you see sort of what our objectives are. We're going to really look at identifying the major mechanisms of pain, both acute as well as chronic and acute on chronic pain. We'll look at how we sort of select therapies based on what we feel is the inciting incident for acute and even chronic pain, and look at some evidence-based issues with the management of pain. We'll also look at opiate versus non-opiate related issues, and then we'll look at some of the major things when we talk about counseling of patients after complete diagnosis and looking at treatment. And then we'll touch with state and federal guidelines. So easiest thing is to define what actually is pain. Pain is not a single entity. It's a multifactorial or multimodal set of issues that involve both a sensory and emotional component. Without the emotional component, we can't really identify and process in the consciousness that stimuli. So we can have the sensory side, which is mainly just physiology, but without the conscious side, we can't really put forth what is a pain response. So we've got to have both of those. And so what that really means is that when patients describe to us or tell us that they have pain and we work through what type of pain that is, we have to realize that there's no test for what we do in the world of pain per se. We can look at imaging and we can look at structure, but structure doesn't equal function. Surgeons are beautiful at fixing a structure and claiming that it is fixed and it looks anatomically correct, and patients should no longer be in pain because the anatomical structure is correct based on some imaging technique. However, the physiology of patients can change, so you still have to believe what they're telling you. So there's no imaging or laboratory tests that can be done. We can do laboratory tests and find out if somebody has a positive rheumatoid factor or positive ANA, or their sedimentation rate is high, or their C-reactive protein is high, or they've got an active HSV infection or something of that nature, but that doesn't necessarily translate or correlate to any pain or pain scale score or something of that nature. So what we have to realize is that when we're dealing with pain, we have to actually talk to people so that we can understand how they're translating their physiological process into a conscious process and then relating that to you as the practitioner to make a decision on where we go from there. So pain is actually a conscious experience. Why is that? Because when we use anesthesia, whether it be general anesthesia or if we use conscious sedation to perform painful procedures, patients don't remember that. So we know that pain then has to be a conscious mediated process, and that involves higher order cortical brain structures to really work through that. So pain on one hand is, there's a definition of that as a conscious process, but that's completely different than the thought of what is nociception. So nociception is actually the process by which a noxious stimuli is conveyed to the brain, and then that electrical process is then filtered through various brain areas and then transmitted back down to the spinal cord, and we'll walk through sort of some of that transmission. So then, in the beginning, if we just think about what in the world is our goal with pain and pain management and pain patients, I really view it as a quality of life issue. I'm not treating a number. Everybody will come in and tell you that their pain is subjectively rated differently, so I'm not treating a number. I'm treating quality of life as it pertains to day-to-day function with the lowest potential doses, with the maximum benefit, with the fewest potential side effects. And what we're doing with the lowest dose and maximum benefit with reduction in symptomatology is helping them to reduce those unpleasant experiences, whether it be acutely or chronically, so that they can have an improvement in quality of life. When we look at pain, the world of pain is often chastised because we use medications sometimes that aren't necessarily seen as acceptable in the community on an ongoing basis because they're dangerous. Our state is in the crosshairs of a huge issue of drug abuse, misuse, and diversion nationwide. There are huge issues. Rightfully so, we need to be concerned. 95% of all opiates manufactured worldwide are consumed here in the United States. 99% of the hydrocodone produced worldwide is consumed in the United States. 2 years ago, guess what state in our great nation ranked #1 for consumption of hydrocodone nationwide, which would be worldwide? The great state of Oklahoma. So anybody who wants to really impress me, and that's not hard to do, but do some sociological research and go get a public health degree and answer me the question, why do we in the United States consume so many opiates as compared to other, and let's not even think about access to care issues in third world nations or non-industrialized nations. Let's think of industrialized nations with good health care access worldwide. Why do we consume those amount of opiates in the U.S.? Is it a training? Is it the Western medical model? No, because the U.S. is full of foreign trained physicians that are here in the U.S. that are writing those medicines for people in pain. So it's not a training issue. Is it an access to care issue? No. The industrialized countries have just as good access as we do. Is it a formulary issue? May partially be a formulary issue, but why is it that pain is treated differently in the U.S. than it is in other countries? I can't answer that question, and maybe somebody can answer that at some point. But if you want to impress me, who's going to Garth Brooks tonight? Yeah. Who's going tomorrow? Okay, only 2 of you. The rest of you are really lame because I'm going for my 7th time. So, anyway, on to pain pathway. So the pain pathway pathway really involves 4 major parts. You have transduction, transmission, perception, and modulation. So what we're having to deal with is the initial stimuli that we're going to use your spinal cord pathway. So who's the smart one in the class that can tell me, well, we just learned that the ascending pathway is what? The spinal thalamic tract, yay. So what's the descending pathway? The corticospinal tract, okay? And so those are actually important sets of nerve transition and transmission areas for medications that we choose to treat patients. So transduction is basically the physiological process where we're taking a noxious stimuli or a mechanical, a pressure stimulus, a chemical stimulus or a thermal stimulus, and we're converting that into an electrical impulse. And so we're using primary afferents, right? So afferent is up and efferent is back down the other way. So afferents are in your spinal thalamic tract and your efferents are in your corticospinal tract. So you all know that, right? Okay. So transduction of that stimulus, then we're basically taking those nociceptors and we're activating those by whatever that stimulus is. And then we're releasing certain chemicals that will sensitize those receptors. And those chemicals that are released at times are very important in why we choose what therapies that we choose. So with bradykinin or cholecystokinin or prostaglandins, other things that are activated at those areas, there's a reason why some acute pain turns into chronic pain, and it's because of peripheral sensitization, and there are certain ways by which that we can reduce peripheral sensitization so that it doesn't then move into a chronic peripheral or even central sensitization. So intervention-wise, is we want to reduce that initial transduction of those stimuli. And so these are going to be things, the simple early interventions such as ice or even splinting or non-steroidal anti-inflammatories, so that we can, not only are we going to remove the initial stimuli that's causing the acute offensive nociceptive response, but then we're going to institute an early treatment such as simple things, ice, non-steroidals. Why? Because what do non-steroidals do? How much pharmacology have you all had yet? Some? Okay. Okay. Why do I not like non-steroidals? What do they do? What are we going to do to my gut? They're going to eat my gut, right? What are we going to do to my kidneys? Non-steroidals are very hard on the kidneys, okay? So in the world of what I do on a day-to-day basis in the chronic pain side of things, patients have usually been through everybody when they come and see me. They've seen primary care, they've seen physical and rehab medicine, they've seen surgery, they've seen chiropractic and massage therapy and everybody down the list. And nobody wants to write opiates nowadays because it puts a big target on your back. So they're crammed full of non-steroidals. So they've been on non-steroidal anti-inflammatory drugs for years. And none of them are taking them with food. And you do kidney function and their creatinine is through the roof. And they're diabetic. And you say, Miss Jones, do you realize what the #1 cause of kidney failure in the United States is? What is it? You had endocrine, right? What is it?
Diabetes.
Diabetes, okay? And so then we cram a bunch of non-steroidals on top of our diabetic patients because they have peripheral neuropathy. We're going to get to neuropathy in a minute, it's a different mechanism, but they've started with some simple things of, well, let me use an anti-inflammatory because that's what, I think I'm supposed to do because I can get a hold of that over the counter. And so what have we done to Miss Jones's kidneys for eons? We're crapping them out. And so non-steroidals are a double-edged sword. They are very important with acute pain, and there are times that we need to use them in patients who may have some chronic inflammatory conditions, but be very wary of knowing for every treatment that you institute, there's going to be something big, bad, or ugly that's on the back end that you really have to be aware of. Okay, and non-steroidals are very important that we need to consider. So that's transductions. Transmission is that once we've generated those wonderful things that we've called action potentials, we're now actually starting to deal with our spinal pathways. So we're basically using those afferents, and we're going to cross at the dorsal horn, and we're going to find our way up the spinothalamic tract, such that we're going to bind in multiple areas of the brain, or we're going to activate multiple areas of the brain that you've not yet discussed. But when we look at pain transmission, those electrical impulses that find their way up the spinal tracts are going to activate multiple areas of your deep brain and ultimately your cortex. And so we're going to deal with the limbic system. So the limbic system is going to contain big structures such as, and not big as in size, but big as in very important, structures such as your hippocampus, but your amygdala. Amygdala is a very important structure involved in memory, especially fear in memory. And the amygdala is very highly involved in pain response. Because if we look at older deep structures of the brain, and if you look at animals that don't have a large cortex, why are those deep brain structures there? Other than your brainstem structures for general physiology to keep us alive, why are those deep brain structures there? Not emotion, because can a chameleon have emotion other than changing colors when it's on your peach shirt? Species preservation. Okay, I'm going to stay alive. So how do I do that? Well, I'm going to use a structure of the brain to tie information to a memory so that I can protect myself. Okay? So if you think about it, in your childhood, your early adulthood, some of you, like Dan, that have had an early, a middle, and a late adulthood, you have memories. And in those memories, I can guarantee you, you have vivid memories of far more negative experiences than you do positive experiences. Am I right? You remember the bad things more so than the good things. Okay? You went out to Drake's last week because you got your student loan check in and you're going to decide to blow a little money so you can have some oysters. You don't remember the good catfish you had, but you remember sitting on the toilet for 6 hours because you ate oysters and you're sick, right? And you're going to remember that next time you drive by Drake's, that, man, I had the bad diarrhea after I got done there. And 2 years from now, when you're on a date and they say, oh, let's go to Drake's, you're going to say, you know, I really don't want to go to that place because 2 years ago I had bad diarrhea after I ate some. You're not going to remember the good catfish 2 years from now, right? There's a reason for that, and it's all about species preservation. And so the amygdala is one of the structures that, although only the size of an almond per se, helps to tie emotion with memory, and it's mainly negative emotion or fear. And so, is it not that something that causes us acute pain is something we don't typically want to reintroduce to our body? Correct? If shutting my hand in that door is an unpleasant experience, don't I want to remember that I want to move my hand out of the way next time I close that door? Okay? And so that area of the brain is very important in dealing with that, and hippocampal structures are very important in dealing with memory, but that limbic system is very important. But you also have connections when we look at transmission into the insular cortex. And unfortunately, in the neuroanatomy and neurophysiology world, insular cortex kind of gets, well, there's this thing called the insula, and we're going to briefly mention it, and we're going to move on. But insular cortex is actually a very important area when we look at pain and dealing with emotional memory of pain. In insular cortex, not so much so as fear. There's some fear processed in the insular cortex, but the insular cortex really deals more with social emotions as well as things like disgust. So if you really get bored one time, how many of you ever get bored in PA school? No? But if you really get bored one time and you want to make me proud, you're going to go across the street to the University Health Sciences Center, and you're going to go into the library, and you're going to look up a master's thesis done by none other than the person standing here in front of you. And my master's thesis was actually looking at amygdala versus insular processing of stimuli. And you're going to find that there is a true difference between the processing of fearful stimuli and disgust stimuli, which weren't necessarily thought to be real different. I'm not going to say that I broke that world open, but it's very clear that there's a difference in how we process those two different types of emotions and tie them to memory, and insular cortex is very important in that. Now, along with the limbic structures, the insular structures, very important, obviously, is your thalamus. How much time have you spent you've not spent any time in thalamus. You're going to get the thalamus. Thalamus is one of the most important structures you can think of when you look at homeostatic mechanisms, but also pain. And when we look at binding of certain medications that we deal with treating pain, the thalamus is very important in that, because there are a large number of opiate receptors in your thalamus. And thalamus has projections to cortical structures and to the limbic system, and there are basically a feedback loop between thalamus and amygdala and back to thalamus, and thalamus to insular cortex and back to thalamus, and thalamus to somatosensory cortex, and so on and so forth, and there are multiple feedback loops. What you're going to find in the body is that there are multiple feedback loops, so that if one structure gives information to the second structure, the response of that second structure may lead down the road to innervating other structures, but there's always a feedback loop to the initial structure to tell that structure that I've responded, and this is how I've responded. Okay? So if we look at transduction and transmission, so transduction, we're looking at those initial noxious stimuli. We're going to try to deal at the source of that. So with transmission, we've entered into that electrical impulse side, so we've got to deal with it a little different way. And so how do we intervene in that second level? Well, that's where you're going to deal with local anesthetics, can stop the transmission of those transduced stimuli. Opioids, it's a little difficult that opiates are here at the start, but there are so many opiate receptors throughout your body that we can deal with peripheral opioid binding, we can do with central opioid binding. You have opioids that are opioid receptors that are in your spinal tracts as well as in your brain. And so really opiates can deal with the entire cascade of the whole pain response. And so opiates can bind to presynaptic receptors. There's also some information with postsynaptic binding. You've got thalamic binding with opiates. And then along with other anesthetics, nerve blocks. So mama's having a baby, and we're going to go in and we're going to do a spinal block. So we're basically attempting to stop that transmission of that information. And then Intrathecal medication, and I would love to spend 2 hours on intrathecal delivery because I think in the world of pain and pain management, we're moving towards more use of intrathecal devices. So intrathecal medication and what we do on a day-to-day basis would be intrathecal pain pumps. So these are morphine pumps. And the use of morphine pump in the last 10 years has been a love-hate relationship. 10 years ago or so, there were a lot of physicians that would say we're not going to use intrathecal pumps, partially because they were managed so poorly. Patients stayed on oral medications and intrathecal medication. It messes with how the brain is actually processing those opiates, and patients just didn't do well. But with the issues we have with abuse, misuse, diversion, unintentional overdose deaths, we've got to find a way to better control opiate consumption, and intrathecal devices is one of those ways by which to do so. So basically, it's an implanted device that's delivering medication into the intrathecal space via a microcatheter, and it's a fully enclosed system that as a medical provider we're responsible for filling the medication into the pump itself, as well as programming the pump to deliver medication as we feel necessary with the patient. Our practice right now we're on track to be the largest intrathecal pump management group in the state, beyond the folks at OU that do spasticity and baclofen. Same pump using baclofen for spasticity instead of putting intrathecal morphine, hydromorphone, fentanyl, bupivacaine, clonidine, whatever it is that we put in it. And the reason being is all about control. Is that if I were to give you a prescription of opiate medication, I can teach you how to use it, I can teach you the big bad and uglies about it, I can teach you the risks and benefits of that, but I can't go home with you, and I can't make you take it as I prescribed it. So there's the element of the unknown, and that's how people sometimes unintentionally overdose. They feel like I'm hurting more, so one of them helps some, so I'm going to take a couple, and then by the time that they've taken more than a few, they may have respiratory suppression, they go to sleep, they just may not wake up because heart quits. So with intrathecal devices, we're under much more control of those, and we're transitioning actually a large number of our patients to intrathecal device so that we've got control of their opiates in a much more tighter fashion. So intrathecal medication actually works at sort of the second little realm of this after we get transduction and then we're into transmission. So perception, this is a brain process, this is a cortical process, this is a little higher area process. It's not necessarily all cortical, because you can have even insects that will have basically some perception of pain, right? Because you can make them hurt. And I guess if you give them a little microphone, they may even scream. So if you take your ant and you get your magnifying glass and you burn your ant, how many have we done that? We should have done that today. Nobody's ever burned an ant with there we go, Garth Brooks and an ant burner. You are on right this day. We're good. So they'll react to that, okay? So there's gotta be some perception that's occurring with that stimulus that's happening. Now, it's not a perception that you or I may talk about as a higher cortical process of conscious perception, but there is, in the sense, a perception of that stimulus. But perception is basically where we're going to recognize that stimulus by a conscious individual. So if we're not conscious, or if we're under anesthesia, perception isn't happening of that noxious stimulus. So this is where we really get into dealing with somatosensory cortex and some of the other cortical processes of perceiving that noxious stimulus so that then we can start to deal with that. So up to this point, we've basically stubbed our toe and we've had the transmission of that information up to the brain. And now we're perceiving that we've done something that's not nice to the toe. Now, one thing that we sort of glanced over was looking at fast and slow fibers. Okay, have you been introduced to that before? Yes, no? Okay, so stubbing the toe is the perfect example, right? So when you initially stub your toe, you have the initial F, right? Those are your fast fibers. It's the, you know, so that's the fast fibers. And then it starts to drop a little bit. You're waiting for it. You have the initial, I stubbed my toe and now I'm waiting. Every one of us has done it. You're waiting. When's it going to start? When's it going to start? And then it starts. And then that's the O-S. Okay, so that's how you remember that. You've got the F and the S, and that's the F is the fast fibers, S is the slow fibers. You know which one happened first. Okay, that's the first word that comes out of your mouth, right? So we basically transduced, transmitted, and now we're perceiving that, and it's much faster, obviously, than what we've gone through. I mean, it's instantaneous that we have activated the nociceptors, we've crossed the dorsal horn, we've gone up the spinal thalamic tract, we've hit the thalamus, we've then innervated multiple areas of the brain, so now we're at somatosensory cortex saying, that is my left big toe, and this is what you've done to that, and I'm not real happy. Why? Because now we're going to get into dealing with going back down the other way. But so, interventions, when we think of dealing with perception, are a little different. So up to this point with transduction and transmission, we've really dealt with some sort, oftentimes, a chemical or a pharmacologic intervention. What we've not brought into the equation yet is mood plays one of the largest roles in the crossover from acute into chronic pain. If you go and look at the chronic pain literature, the one thing that is oftentimes either missed, overlooked, or unfortunately not highly reimbursed by insurance, so patients choose not to go and deal with that, is the emotional aspect of pain. And we know, and there's some really, really good research, that if we will intervene early in an acute process that has the potential to develop into a chronic pain process, if we will intervene earlier from the emotional side, from the mood side, from the cognitive behavioral side, we can thwart a fair bit of movement into the chronic pain world. So that perception is where your patients are going to be telling you, this is what I feel and this is how it makes me feel. Now, it's not up to me or you to tell them how they should feel or the intensity that they should feel. That's an individual conscious process. But what our job is to do at this point in intervening with the perception side is reduction in depression, anxiety, other things that go along with reduction in day-to-day function or lack of independence or whatever it may be because of an acute injury or an acute pain setting, so that we can attempt to thwart the transmission into a chronic pain situation. And the emotional side of it is very important for you as a provider, because patients who have been injured in some way, form, or fashion, so we're beyond just I stubbed my toe. Let's talk about somebody who's had an automobile accident and they've had a femur fracture, and their job, it requires them to engage in, let's say they're in landscape. They've got to bend and lift all day long, and they've got to walk behind even a self-propelled lawnmower, and that's their livelihood. And they've got 3 kids at home, and so mom is a stay-at-home mother because they're all under the age of 5, and she doesn't work, and they have no other income. What's the impact to this guy, not only financially, but psychologically? And you have to be prepared to you know, we can all be well armed with the best research there is to, oh, well, I know that if it's this type of pain, I should use drug X. Or I should use ice, and then I should splint, and then I should cast, and then I'm doing so good. But I've got no idea how to talk to patients. And I've got no idea how to deal with the emotional aspect of what's really happened just now in their lives. And we see this very, very commonly in workers' compensation cases. Somebody's been injured on the job. They've had a reduction in the ability to perform their tasks at work, so they've been put on some sort of limited duty, or they may be off of work because of their injury prohibits them from continuing to deliver mail or to engage in jet aircraft mechanic work at Tinker. And now all of a sudden, they have a significant blow to their psyche, and these people become very depressed. They're anxious about their financial situation, and they start going through the entire grieving process. So everybody here has had general psych, correct? You've not had, in undergraduate, you've had general psych. You've not done your psych side yet. That's next, this coming up, right? So you probably at least remember the basics of the grieving process. So in the beginning, I'm in denial. I'm in denial that this is happening to me. It's like when Dan called me and said, will you do this lecture? It's like, I'm in denial. He's not really calling me, is he? And then we get angry. So we're in denial, and then we get angry that this has happened to me. And then we start bargaining. Okay, did this really happen? No, well, it might have really happened, but I can start bargaining through, well, I can do this, or I can do that, or I might be able to do this if I could just do that. And it's not until we move into acceptance that we can actually work towards resolution. And so many patients that transition from acute to chronic pain are stuck in denial and anger. And there's no time course on the grieving process when it deals with pain. Or really, loss of a loved one, your favorite ferret died, your tomato plant died, you know, you got an F on your whatever exam, you know, you still grieve. And there's no time course on that grieving. You know, I'm still pissed off that I got a B in some class in PA school, but, you know, that's okay. I'm still angry about that. I'm not really, but, you know, it can happen. So you've got to really deal with the emotional side is just as important, and at times more important, than what medicine do I choose or what intervention do I employ, because the most important thing in evaluating any patient is what? Is it a test? Is it the intervention that you choose? What is 85% of medicine?
History?
It's interpersonal skills. It's talking to people, okay? It's your history, then it's your physical exam, and your number one intervention needs to be, if I was in this patient's shoes, how would this make me feel? And what are we going to do to keep that in mind when we employ some sort of intervention? Okay? And that's how we intervene in the perception side. So then descending modulation, this is your descending pathway, this is your corticospinal tract. And so descending modulation, there's a large amount of research that's been done at descending pain pathway modulation, and some of the biggest stuff that you'll actually see with descending modulation are certain neurotransmitter systems such as norepinephrine, serotonin. These have been proven to be very fruitful in descending pain pathway modulation. Opiates can also deal with descending pain pathway. Sodium channel. Sodium channels can be also intervened with ascending and descending pathways. So when we look at that, you're really trying to modulate or reduce the sending of information back down to the spinal cord so that then it goes out to the periphery. So that then we're dealing with what it is that I know that I just stubbed my toe. So I did the action, we transduced it, we transmitted it, the thalamus sent it everywhere, somatosensory cortex said send it back down, that hurts, and now I'm dealing with it in the periphery, okay? And so along those lines, there are multiple ways by which we can intervene in that. So what's our intervention if we're looking at the descending modulation? So this is where we may look at certain serotonin norepinephrine reuptake inhibitors. So one of those that is at least approved for pain is duloxetine, or trade name Cymbalta. Old tricyclic antidepressants, things like amitriptyline, the old trade name Elavil, not so much so as nortriptyline, but nortriptyline is also a tricyclic. Believe it or not, cyclobenzaprine, which is commonly used as a muscle relaxant Flexeril, it's a tricyclic. And so we know that medications that modulate serotonin and norepinephrine can be very beneficial at modulating descending pain pathways, okay? And so those medications can be very effective, but they carry baggage. Now, they're not controlled, correct? Those are non-controls. But what does serotonin do to platelet aggregation? Serotonin will change platelet aggregation, such as our platelets don't, let's just use the word, stick together as easily, okay? So now let's think back to our patient that we've decided to use non-steroidal anti-inflammatories with on a chronic basis, and we're going to be that practitioner that says, I don't want to use opiates because of abuse, misuse, diversion in the state of Oklahoma, so I'm going to use duloxetine because it's approved by the FDA for back pain, joint pain, fibromyalgia pain, and I'm going to add duloxetine to this patient. Have I thought about that it is a serotonin and noradrenergic reuptake inhibitor, and by introducing a serotonergic drug, I've changed platelet aggregation. What do my non-steroidals do to bleeding time? So now I've got two drugs together that put me at increased risk of gastrointestinal bleeding. You got to think about it. So every intervention that you employ, although this seems to be a better choice than dealing with opiates or some other control drug, you've got to now think about, well, Jamie told me in the beginning, if I'm thinking about modulating transduction, I'm going to use ice and a non-steroidal. And if that pain is persisting, you know, let's say we've got a chronic joint pain, chronic knee pain patient, and we're really early in the treatment guidelines for osteoarthritis of the knee, and we may be, let's say that we're a stage 2 osteoarthritis of the knee, and we're doing non-steroidals, whether it be topically applied or oral. Topical anti-inflammatories still have absorption into the bloodstream. It's a great study that was done in Europe about 5 years ago looking at topical diclofenac. They put it on knee X, and guess what? In 2 days, there was a appreciable amount of diclofenac in the synovial fluid of knee Y. So we know there's still a fair bit of absorption into the bloodstream, even with topical anti-inflammatories. So let's say we're using the topical anti-inflammatories in this patient that's got a stage 2 osteoarthritis of the knee, and we're going to advance in those guidelines to the next step of let's use something like duloxetine that's approved for the treatment of joint pain by the FDA. And so I'm going to institute that. And now all of a sudden, Mr. Jones, whom I thought I was doing a good job with because I was avoiding putting him on hydrocodone 325 3 times a day, has now got a GI bleed because I didn't tell him that they needed to take it with food and be careful about platelet aggregation and bleeding time. And he ended up in the hospital because he had a perfed ulcer, because he didn't tell me that he had bad reflux, and he was just treating over the counter with ranitidine. Educate your patients. It's all about talking to them. Don't just prescribe something and think that I need a pat on the back because I've done something good. You gotta educate them. I've seen it many times. People get themselves in trouble because they think that they're doing a good thing. And without educating patients on, the most important thing you should do on educating patients with medication, start with the side effects. What do you do when you watch TV? My younger daughter, she's 12, but even well before the age of 12, she asked me, oh, she was a little bitty. She said, Dad, why would anybody take any of these medicines on TV? And I said, well, why do you ask me that? She said, because they spend 10 minutes telling you that pretty well it's just going to make you die, and why would you want to take that? But you've got to be upfront with what the potential adverse effects are, along with what are the potential positive effects of these different medications, because they all are double-edged swords. Part of your intervention as well here is you've got to think of anything past perception. You're dealing with the emotional aspect of these patients. And then in the descending pathway, this is where we also can deal with spinal cord stimulation. So in patients that have chronic radicular neuropathic pain in the upper or lower extremities, we can employ what's called spinal cord stimulation. It's a small electrical device that's implanted that we use paddles that are implanted up next to the exiting nerve roots, and we basically use it as a distracting device. And so most of you have probably seen a TENS unit. You know what I'm talking about, an externally applied device. TENS units actually, about 7 years ago, a study was done in Europe that pretty well said quit using TENS units for low back pain because there's no benefit whatsoever. My argument is, beyond it being a distracting device, TENS units really are used way back in the process of transduction and transmission. We're basically just interrupting those signals. There's no real treatment that a TENS unit is providing. It's a distracting device, okay? So here's the deal. My knee hurts, so I'm going to put a TENS unit on. What am I focused on now? My finger hurting. So when I take my finger hurting away, what happens? I'm focused on my knee again. So TENS units are basically a distracting device. They're not providing any necessary form of treatment. Spinal cord stimulation is the same thing. It's just, instead of an external device, it's an internal device using electrical impulses at different wavelengths and different voltages to distract the nerves so that we are not sending those electrical impulses to the lower extremities or upper extremities, causing radiating or radicular pain. A very common use of spinal cord stimulation, let's say we've got an individual that's had let's say they've had a disc that's ruptured at L5S1 and they're getting left lower extremity radiating pain, and despite laminectomy and discectomy or even fusion at L5S1, they're persisting with an inflammatory response such that they're getting left lower extremity radiating pain, and the neurosurgeon looks at it and says, listen, the structure looks fine, I don't see any foraminal narrowing, I don't see any spinal stenosis, it looks fine, but the physiology of the body has changed. Keep in mind, surgeons love to fix structure, but they can't fix physiology. And so commonly surgeons will tell you it's fixed, they shouldn't still need pain medicine, but oftentimes the physiology of that body has changed. So we have left lower extremity radiating pain in this individual. They may have failed tricyclic medication, they may fail gabapentin or pregabalin, which are Lyrica and Neurontin, which can be very beneficial with nerve-related pain. And so we may consider using spinal cord stimulation or the implanted device. Why? As a distracting device that the patient can have some control over to reduce their radicular pain or their radiating pain. There's been some great research recently with spinal cord stimulation, in that we used to have a problem with, if we would turn the frequency up on those devices, we would have to turn the voltage up, and by doing so, we would either innervate other nerves that would cause discomfort in other areas. So if we would over-innervate nerves that potentially we're supposed to be dealing with lower extremity, we may get a little referred or pain up into the abdomen and other areas that were really uncomfortable for patients. Well, what we found is there's been some really neat research looking at very high frequency yet very low voltage spinal cord stimulation. And several of the big name spinal cord stimulation manufacturers have perfected, it's called silent stem. And the majority of our spinal cord stimulation patients, if they have the ability to have their stimulators reprogrammed, we're giving them silent stem. That way, they don't have to worry about, because oftentimes patients will say, my stimulator is very effective if I can get it turned up high enough. And if I can tolerate that, my leg pain goes away. But I start getting pain into my abdomen, or I start getting other innervation further up my back, and it's just uncomfortable. So my stimulator, it works to some benefit, but not as much as it needs to be. We put them on silent stem, and now they're wonderful, because we can really turn that frequency up without a lot of voltage, and so they're not having that innervation of inappropriate areas. So there's also been a really good study come out of Europe recently that said we shouldn't be reserving spinal cord stimulation for failures. Right now in the US, spinal cord stimulation is basically reserved until somebody has failed a surgical intervention. So you're dealing with post-laminectomy syndrome or post-surgical back, post-surgical neck, failed surgical neck, failed surgical back patients. The new line of thinking is now that we really need to be looking at spinal cord stimulation earlier in our treatment methodologies so that we can reduce centralized sensitization. So when we think about it, and I told you we weren't going to go through real specific conditions, but let's talk about the wonderful world of fibromyalgia briefly. So I will tell you that going through school, I would tell you that fibromyalgia was a trash can diagnosis. It was a diagnosis of exclusion. You went through everything else, and you couldn't figure out what was going on. So that's what you gave them a diagnosis as. I can tell you, after being in clinical practice now for almost 15 years, it is real, and it's a very interesting process that's happening in both your brain structures and in the spinal cord. So I want you to think about your spinal cord and the ascending and descending pathways as having a filtration device in there, okay? Part of that filtration device is your brain, is some of your higher order areas in your brain. And so your perception, so your somatosensory cortex, and then all of these other areas, the limbic system, the insular cortex, so forth, prefrontal cortex, these areas are constantly monitoring the information that's being sent up your spinal cord to then send it back down to tell you what's going on. Is this my clothing? Is this my bed sheets? Is this the bath water? Is this a hug from a loved one? So I'm perceiving these stimuli. Well, in patients who develop a fibromyalgia type process, it appears as if their filtration device says the hell with it. And what we think happens is that because of repeated insult through these noxious stimuli, through these nociceptors, that their filtration devices decide that they get worn out and tired. And so they now decide to stop filtering information. So let me give you an example. Let's pretend that we go to Disney World. How many have been to Disney World? Okay, much better than Garth Brooks. Okay. So we go to Disney World, but the first day we go to Disney World, we get a brand new pair of shoes. Because I'm not being sexist, but women do this for some reason. I mean, I've been married 20 years, and we go on vacation, my wife's got to get a new pair of shoes. And I don't understand why that is. But you're going to get a new pair of shoes when you go to Disney World. And you're going to put those new shoes on, and you're going to walk in them all day long. Well, what commonly happens with a new pair of shoes that aren't broken in? We may start to rub a blister, okay? Now, but our Disney trip is 7 days. And our kids are 18 months and 2 years old, and never going to remember this damn trip. But by golly, we took little Johnny and little Susie and we're going to do it for 7 days. We're going to do every park there is. And we're going to take little Johnny on the Yeti ride, although it's going to scare him to where he pees in his pants, but we're going to do it anyway. And I'm riding the rock and roller coaster 12 times because by golly, I paid to get into this park. And so what are we going to do for 7 days? We're going to go to every single park. And today I put on my shoes the first day, and by the end of the day I've got a little blister. Let's put a little Band-Aid over it. Day number 2 I do it, and it's uncomfortable. Day number 3 I really start complaining. Day number 4 I'm getting to be a grouch. Day number 5 I'm about ready to explode. Day number 6 cut my foot off. Day number 7 I couldn't get home fast enough. Okay? What have we done? By repeated insult, we've sensitized that area, okay? My older daughter is one that she loves to use this term. She loves to use the term of, let me say how to put it nicely. My kids are wonderful, by the way. I've got the 2 most beautiful daughters ever. She will tell you that don't engage in repetitive motions, meaning that if you're sitting next to her, let's say grandma's sitting next to you and she's just rubbing your arm, you've been next to grandma that just, for 2 hours, just rubbing your arm, okay? Well, my older daughter is one that, she'll be one that's like, okay, listen, 1 hug was enough, back off, Jack. No, none of this repetitive, stuff. Well, what's happened with the repeated insults or the repeated activation of those nociceptors, we've sensitized that particular area such that now, where we used to be able to put our sock on, it was a little uncomfortable but not too bad. Now it's the get the sock away, no way the shoe is going on, I'm not getting in the bath water, don't put the bed sheets on me, turn the fan off because that hurts, and if you get anywhere near me, you're getting a black eye, okay? So we've sensitized that area because of repeat insults. This is what happens in the development of central sensitization in myofascial pain or in fibromyalgia. Because of repeated stimuli being transduced, sent through transmission, up your spinal cord, processed by the brain, and sent back down, for some reason in some individuals, their filtration system decides that I don't care if this is a hug from a loved one, if this is the bath water, if this is a sweatshirt, if this is a ball cap, it's all uncomfortable. Okay? Why is that? We don't know. But there's one very common factor that you will find in about 90% of patients who develop a myofascial global widespread pain syndrome. Somebody want to guess what it is? It's the most difficult conversation you will ever have with any patient.
Is it psychological?
Abuse. Abuse. Childhood trauma. Not so much so physical, but it is very common that adolescent or pre-adolescent sexual abuse or trauma will be in the history of a patient who develops a chronic global widespread pain syndrome. Therefore, the connection that I talked about in perception, early intervention for cognitive behavioral therapy or other coping mechanisms, working through the grieving process is very, very important. Now, not only in your patients who develop fibromyalgia, I can tell you if you go read my chart notes, every patient that we see in initial history physical, I ask them at some point in time in their visit, it's usually embedded in the part why I'm asking them if they've ever been in jail, drug or alcohol